So good afternoon, everybody. It's a pleasure to be here this afternoon. We are going to hear one of the biggest experts in living donation and transplantation, kidney transplantation, a qualified expert with extensive experience in the field, Frank Dorr, who works at the Hammersmith Hospital, Imperial College of London. And Frank is going to entertain us for the next half hour about living kidney donation and describe his experience and his extensive experience in this very unique field in surgery and transplantation. Before we start, I'd like to give you a small info regarding how we are going to interact. You will be able to ask questions. Questions will be answered mostly at the end of this talk, and you can do it by pressing the button of the Q&A right at the below the screen, where you can see the Q&A. Now, I don't want to take away any more time. I want to thank Sebastian Roca for making this webinar possible, and we can start. Frank, if you want to take the lead.
Thank you very much, Jacopo, and thank you to the organizers for having me, and of course for you to be present at this webinar. I was asked where I would like to talk about, and this is, as Jacopo was alluding to, one of my favorite topics in surgery and in transplantation, and I hope to inspire you with some personal views on living kidney donation as one of the most unique fields, I think, in surgery that we know. Trying to advance my slides, so always some disclosures. When we talk about people with end-stage kidney disease, there is a big problem because there's lots and lots of patients on dialysis, and only about half of them are waiting for a transplant, and only a proportion of them, a third of them or so, will be transplanted every year. This results in general in Europe in about 3 to 5 years waiting time. Some countries a bit better, some countries a bit worse. And thousands of patients die on the waiting list per year. We don't really know in Europe overall how many patients are removed from the waiting list every year. And especially the people who never make it to the waiting list. And this is a story that one of my mentors in living kidney donation, a nephrologist called Willem Wijmer from Rotterdam, who's now retired, was always inspiring us about. So there is a real incentive to do something about this. And I was going to ask you, actually, and you can actually vote for this question, what the estimated 5-year survival is of a dialysis patient in general, roughly. Is that 25%? And hopefully we can get the survey going, so you can answer that online. Is that 25%? Is that about 50% or 65% or 80%? Will be very interesting to see your vote, and we'll give you some time. I don't know how much time is needed, but I don't think we're with hundreds of us, so I think it should be finished soon. So the estimated 5-year survival of an average dialysis patient in Europe. Will you let me know when people have voted? Okay, so it's that's always nice if there's a bit of a widespread picture. Obviously, it's not 80%. It's also not 25%. It is roughly 50%. And of course, that depends on age and comorbidities. So the older you are, the more likely it is that you won't survive 5 years as a dialysis patient. You can see that in the next slide here. This is a Dutch prospective study where they followed patients on dialysis for years. It's a national registry, so quite reliable data. And you can see that the 5-year survival roughly is about 50% or a bit lower even, if you don't look at all the different ages. But you see that for Even for young patients, the 10-year survival on dialysis is about 40 or 35%, which is worse than some types of cancer. So it's good to take this into account when we look at increasing the donor pool, because for kidney transplant, obviously, is the best treatment for people with end-stage kidney disease. We've expanded the criteria for deceased donors because there's simply not enough transplants for the need of numbers for people that need a transplant. We've expanded the criteria, and we have included reconditioning strategies such as machine perfusion and other strategies. Many countries have or are in the process of changing the legal system for organ donation from opt-in to opt-out. This may change the culture and may, in decades from now, result in real changes. And also, people have taken a view that that active promotion, quote unquote, of living donation is the way forward, because we can do so much more with living donor transplantation. It's not just a better quality. We can do preemptive transplantation. We can exchange kidneys between centers and countries even. We can have altruistic donors, otherwise unspecified donors, to donate a kidney anonymously, and we can do transplants across the ABO or HLA barriers. This might require legal changes because the legal system in Europe is very different per country with regards to living donation. I'm always stunned with European directives in place, how many differences there are in transplant laws in Europe. And that's really something that I would like to do some work on and continue working on, actually, to try to get a more pan-European view on this. It's nicely described in this book here by Leonie Lopp, how this is all regulated. Quite heavy stuff for a surgeon, at least. Okay. So we know that from various surveys and published studies that the practices in Europe vary with regards to living donation, how people organize living donor programs, how this is regulated, how many people are accepting certain types of living donors or not. Nicely published in this paper in Transplant International. And the other quite recommended paper is a paper that we did with our ELPAT group, Ethical, Legal and Psychosocial Aspects of Transplantation Working Group of ESOT, on the reflection on the EU directives for living donation and what actually we would recommend on top of that. So how to increase this living donor pool? I think we have to go to extremes to disincentivize living organ donation, because it still seems to be reserved for the happy few in many countries, if at all. And even in countries that I worked in the Netherlands and the UK, we can still push for more living donation to happen. But I always feel like this black dog here, surrounded by sheep trying to suffocate me in the world of trying to expand living donation, because it's often you feel alone or quite in a difficult position, as you can imagine. But if you look at the advantages of living kidney donation, it's clear why we have to do this. It's an elective operation, so no operations in the middle of the night or in the weekend. It has lots of advantages for the recipient. I think one of the most important advantages is the ability to really deliver preemptive transplantation and avoiding all the complications of dialysis and its morbidity, but also mortality, as I've shown. And I also mentioned already what else we can do with paired exchange and unspecified donation and incompatible transplantation. We select the donors. They have to be healthy enough, and also the kidney function has to be great enough for them to survive on one kidney for the rest of their lives. So that results in very good quality kidneys overall, compared to people who just died, and the dying process, either as a brain dead donor or as a DCD donor, will affect the kidney quality at some stage. The cold ischemia time is normally short, so that should result also in better graft function. And we can do impossible transplants and very difficult cases, because you can plan for them, make sure the right team is there, pre-treat where pre-treatment is necessary, such as for FSGS, for example, where high degrees of recurrence in the transplanted kidney can be seen, and pre-treatment can solve that. And of course, with incompatible transplants, we can desensitize recipients by removing antibodies against a particular donor. And also it has lots of economic advantages for society. So one kidney transplant from a living donor can save up to about 800,000 euros in 10 years, which is not insignificant per transplant. This is one of those impossible transplants we did back in Rotterdam when I was still there. This guy in the middle was a recipient of a 7th kidney transplant, highly sensitized, got desensitized with eculizumab treatment as well. And he had an estranged sister who then turned out to be a 000 mismatch donor. So a perfectly matched donor for this recipient. And this is more than 8 years ago. And he's still doing well, became a teacher, became a husband, and donated, and got 2 children as well. He didn't donate his 2 children, sorry. The picture in Europe, as I said, if you look at percentages of living donor transplants per million people, you see that a few countries are outstanding. The Netherlands is really leading the way. This is pre-COVID on purpose because the post-COVID and COVID years are not really representative of the activity. Hopefully next year, the figures will look like pre-COVID again. But you see that a few active countries, Netherlands, UK, Denmark, Sweden, and of course, other countries are active as well, but to a lesser extent. And just outside the EU, obviously, Turkey is leading the way, but they lack really deceased donor programs. The attitude of transplant professionals towards suitability of living donors also varies enormously. So there's inequity of access across Europe, which is a massive thing, I think, in general in healthcare and surgery, but also in transplantation, and especially for living donation, as to what people accept in terms of suitable living donors. So if you're a recipient in country A, you may not get a living donor from your brother, but the same brother in a different country would have been a suitable donor for you if you would have lived there. So inequity of access. There's also inequity of access within countries, because we know that socioeconomic status also determines your chances to get a living donor transplant, as we did in this study in a UK-wide study that was recently published as well. So we do know that lots of people lack access to living donation, and also health literacy, another very massive topic that influences your chance to receive a live donor transplant. And there's an ethnic disparity, unfortunately, as well. This is a study from the UK, where actually there were differences in people who are from Black, African, or Asian backgrounds compared to Caucasian patients. And they identified why this could be. And there's many cultural and religious barriers towards access to healthcare, but specifically for living donation, which we are studying at the moment, and we're trying to solve as well. So living donation is a unique thing, and I can't emphasize enough this. We're operating as surgeons on healthy people. These people don't need this operation, and yet we're removing a vital organ from them. So we can only make them worse, basically. That's the bottom line. Because if you are a cancer patient and you do a resection and you have to resect a few additional organs, the patient will be very grateful, even if there are complications, if the cancer is out. For this operation, you cannot justify any complication, basically. So we can't let them die. There should not be any complications. The kidney should come out perfectly fine. There should not be long-term risk to these donors, and they need a good quality of life and a quick recovery and return to normal life after their living donation. So quite a responsibility, in all fairness. And I've been doing this for quite a long time, did quite a lot of these living donations, and it never becomes really normal. It's still, I'm passionate about it, but actually we're taking risk as a surgeon as well. So I would like to ask you now for the next survey question, what is the perioperative chance to die of a living kidney donor, so a live donor nephrectomy? Is that 1 in 50? Is that 1 in 200? Sorry, that's a spelling mistake. That was my fault. It's 1 in 3,000 and not 30,000 in C. Or is it 1 in 10,000? So C should read 1 in 3,000, and the rest is correct. Let me have your votes, please. Would be very interesting to see if you have it right. And again, we'll take a minute to see if the answers are coming through. So there you go. Yeah, so most of the people know, of course, the published results. 1 in 200 was a bit of a tricky answer because that is the sort of perioperative mortality for live liver donation, roughly. 1 in 3,000 should be the answer, although that is predominantly derived from one study. If you look at meta-analytical data, systematic review data, we found actually that it's more close to 1 in 8,000. But of course, there's publication bias in that. So most of the people quote a 1 in 3,000 perioperative mortality risk. So I mentioned already the major surgery on a healthy person is not a big operation as such, but it's major in terms of the impact. And there's no therapeutic benefit to the donor. Obviously, the benefit to the donor is often that they help a loved one, and that by a healthier loved one, you also benefit as a partner or sibling or parent or child to have your family member in a more healthy status. So the intraoperative complication rate is about 2.3%, largely very mild Clavien-Dindo 1 complications, but occasionally people have to be taken back to theaters for a bleeding or worse. And the post-operative complication rate is about 7%, and this is largely wound-related matters. And I'll show you a few more. So really, we have to balance the recipient benefit, which is huge of a living donor transplant, versus the donor risk. And if you keep the risk as small as possible, the benefit is even more justified. But it is an individualized approach, and it requires a lot of discussions, good workup, and informed consent. I'll come back to that. But of course, in our system, when we look at it ethically, there is autonomy of the donors. So they want to donate and help their loved one. But there is an awful paternalism in the healthcare system. We, as doctors, surgeons, and other healthcare professionals, quite often impose our own views and values. And of course, we have to protect more than just one patient and one donor. We have to protect our transplant program, our hospital. The transplant program in the whole country may be affected if we are taking too much risks on an individual basis. So it's not just that particular donor to that particular recipient. For us as healthcare professionals, we have to protect our program and transplantation in general. So that's nicely published in another LPAT paper recently in Transplant International, where you can see some considerations that I was alluding to. So what are ingredients for a successful live donor program? Well, it would be very helpful, of course, to have a national strategy, a national framework for living donation and live donor kidney transplantation. There's quite a good choice of national and international guidelines. I present here the BTS guidelines because I wasn't involved in them, so I can talk about it freely. I really think it's a very good piece of work that is available online. I'll show you in a minute for everyone to see. Very robust document. You need a strong multidisciplinary team. And of course, modern surgery is all about multidisciplinary team approaches and collaboration with referring units to make sure that everyone can share their vision into particular patient and donor decisions. The workup needs to be robust of a living donor. It needs to be a good medical workup for the short term, but also the long term. Surgical as well, same issue. And of course, a psychosocial element is almost as important as the surgical and medical aspects. And that will lead to absolute versus relative contraindications to donation, if any. And those are, of course, up for discussion in the team and then present them to the patient and the donor. So as well, we need a robust informed consent procedure. And it's really not a tick box exercise. It's really a process where you go through the particular risks a donor is willing to take. And especially in this day of age, it's important, what is the risk for that person in front of you? So quoting a 1 in 3,000 mortality risk is pretty meaningless, to be honest. We have to then reflect, is this particular donor in front of me looking at a higher risk to die or not? Is there a higher risk for end-stage kidney disease when he lives or she lives with one kidney alone or not? And try to convey that with the patient and their loved ones if they want to be involved. Obviously, we need to make sure our operations are safe, and we have techniques to guarantee safety. A very important part that I'm passionate about as well is training of surgeons. It's very difficult to train people properly if the numbers of live donor transplants are low, and it requires quite a good number of procedures. And the books have not been closed on that topic, what the exact learning curve is. Some people say that after 30 live donor nephrectomies, you can do them by yourselves. I would argue that probably for the straightforward ones, this may be true, but if they become a bit more complex with multiple vessels or other surgical complexities, such as previous abdominal surgery or obesity in the donor, then really we start looking at more than 100 cases. So there's various literature reports on learning curve, quite interesting to see and to reflect on that. Long-term follow-up is really, really important, that we have organized that for our particular unit, and that we motivate people to actually come to the yearly checkups. I always say it's like an MOT of the car, to see if any risks that they would have for the long term can be modified. And also it's really good practice for governance that we actually know what's happening to our donors. Safety nets are super important. One of them is that some countries in Europe, but not all, have sort of a law in place or a rule in place that any previous living donor will have priority for a transplant should they ever develop end-stage kidney disease themselves. So that's sort of the ultimate safety net. And normally that resonates really well with the living donors that I see and inform them about this. And also gives us, I think, as healthcare professionals, quite a bit of a relief that we know that at least that's what we can offer them should things go bust. And then education, not just to the patients, the donors, and our colleagues, but basically to the general public and other people involved in healthcare, like policymakers and insurance companies or like national health services. In the UK, there has always been a living donor kidney transplant strategy and framework. And recently, the organ donation and transplantation framework vision was published, where living donation is now an integral part of organ donation and transplantation in general, which is, I think, quite good that it's integrated in the overall picture of donation and transplantation. This is just an example, again, pre-COVID, the numbers of people on the list, almost twice as much as the numbers of transplants that are generated per year for kidney patients. And the number of living donor transplants in gray has been stable or even gone down a little bit to 1,000 per year in the UK, where deceased donor transplants have increased in number, both for DBD as well as DCD. So we have a static living donor activity. Not sure why exactly this is, but it could be related, of course, to the publications that came out about the long-term risks of living donation that are not as they were previously published, basically saying that living donors live longer and that actually there is no increased risk for anything. But we do know that for living donors to get end-stage kidney disease themselves. But the actual risk, the absolute risk is still lower than the general population. So that's really reassuring. So this is a picture of country activity again on living donation rates, and Netherlands leading the way. US still better than most of the European countries, actually, and the UK, at least in 2018, was doing all right compared to 2010, where they were sort of in the 6th place. So it's not a competition, obviously, but it just shows you the picture in Europe and how different it is per country. Another passion of mine is that we all learned in medical school that kidney patients at some point need to start dialysis. Then they may be activated on the waiting list for a deceased donor transplantation. And if they're really lucky, they may be considered for a living donor, kidney transplantation. So that is probably a very, very lucky patient after start of dialysis. This is sort of the conundrum. And you still see that in most of the countries, that most people first go on dialysis and then we start thinking about transplantation. Whereas in my view, transplantation should always be considered as soon as possible and early on in the disease process of a kidney patient, with the aim of doing a preemptive live donor kidney transplantation first. No need for dialysis. But of course, if we can't make that because it's an acute issue with the patient that needs to start dialysis immediately, otherwise they would die, then of course you can still consider a live donor transplant after dialysis, and you can still at the same time waitlist the patient for deceased donor kidney transplantation. But many people have thought about it also, what is the right timing for a preemptive transplantation? Is it guided by the GFR only? Or should we also take into account basically other blood tests and other parameters? And the latter is true. It's a combination of the clinical picture, the GFR, and other laboratory measures. But most important, I would say, is not to miss the boat of a preemptive transplantation, because it offers many advantages compared to non-preemptive transplantation. I'll get back to that in a second. So we really have to move barriers to opportunities. And again, this is an LPAT paper to see how we could do that and how we could change the culture slowly in favor of preemptive transplantation, because the evidence base is quite strong. And there's lots of misconceptions still about preemptive transplantation. People know, of course, that it avoids the dialysis-associated comorbidities. It avoids, PD catheter or fistula creation. It is very cost-effective, but there's misconceptions in the system where people think that there is an increased risk of rejection due to the fact that they're not so uremic and therefore not naturally immunosuppressed. There's no proof for that, and I've not seen any science to support this. And also, they say, they will not be compliant with their immunosuppressive medication because they don't know what it feels to have dialysis. They should first have some dialysis before a transplant, because then at least they can appreciate how important it is to take their medication. Again, no proof at all, and I would say all completely bollocks. There is evidence, though, that there is less delayed graft function in preemptive transplantation. This is meta-analysis that is going to be published soon. But also the risk of dying in 5 years is also less for preemptive versus non-preemptive. And also the graft survival is better for preemptive transplantation. So there is no increased risk of rejection or graft failure as suggested by others. So lots of papers actually, and lots of evidence to show that this is the preferred renal replacement therapy, live donor kidney transplantation preemptively. And of course, we need early referrals of those patients. We need to get them in our units early on. This is also what the patient wants, by the way. They want to be educated early on. They need to adapt to the fact that they have a chronic illness that is actually leading to organ failure. And then the prospect of dialysis is really, really difficult to digest for many people. So we need to start education early when there's like 30% graft function, kidney function left. You may educate too much, but at least people know that should they develop end-stage renal disease, they can still have time to find a living donor and come to peace with that, and aim to get transplanted whenever the GFR is declining and well under the 20%. In the Netherlands, in Rotterdam, when I was working there, we transplanted people when they had a living donor and were hitting a GFR of less than 20. So again, there's a public health justification to also make sure that we change the default to preemptive living donor transplantation, as we recently published in this public health journal with a group of European collaborators. And this is really important to realize, and there's lots of blockages in the system. Now we move to another advantage of living donation besides preemptive transplantation, is when I want to donate to my sister, but our blood groups are incompatible and she may have antibodies against me because of pregnancy, for example. It's not the end of the road. If you have a program that allows a kidney exchange, for example, this is a direct exchange from donor A donating to recipient B and donor B donating to recipient A, and thereby creating compatible transplantation. And you can make it as crazy as you want in a national program. You could do it directly. You could do it in 2, 3, or 4-way chains or pools, if there's what they're sometimes called. But again, there's inequity of access because not every country in Europe has the same extent of kidney paired exchange programs, if at all. There's still many countries who don't have this, and the law doesn't allow for this, for example, in Germany and most states. But luckily, the picture is changing, and there's a European collaborative, the NCAP group, that is trying to make kidney exchange possible in the whole of Europe. And I was recently in Sweden, in Gothenburg, where they presented their 10-year experience with the pan-Scandinavian kidney paired exchange program between 7 countries. And, many transplants already have taken place, I think more than 50 or 60. This is really delightful to see. And there are some other countries who collaborate with each other in Southern Europe, between Italy, Spain, and Portugal, small numbers, but happening, and also between Czech Republic and Austria, there have been some exchanges. But we could do much more. And if you look at how Eurotransplant, for example, functions, we could actually add this onto the Eurotransplant logistics, or the Scandia Transplant logistics, or the Southern Alliance Transplant logistics. It's not that difficult, but of course, it requires a lot of work and a lot of trust to make this happen. So the kidney paired exchange program successes are also depending on the fact as to whether altruistic or unspecified donation is allowed. So this is donation to an anonymous and unspecified recipient that is not genetically or emotionally related to the donor, because these donors can actually generate, start whole change of transplants and make lots of transplants possible that otherwise would not have happened. There's still a lot of awareness that could be raised here, as we wrote with the LPAT group on this particular topic, to make sure that we inspire more people to see if we can make this a legal activity in every single country in Europe. And there should not be a reason why it's not. Of course, there's always the fear of organ trafficking and illegal transplants happening, but actually this is the opposite. This is really people who, from an endogenous motivation, want to help others without any benefit for themselves. And then if you even know that more transplants are being made possible, it's even better. So we know even where altruism is located in the brain. So if you scratch yourself here behind your ear, you find your superior temporal posterior branch. And if that's a very active part of your brain, then you're more altruistic. And if not, then you're not so altruistic. Lots of people don't understand why people want to do this. And even though you may not want to do this yourself, I think we should still respect and even try to really understand people's motivations, why people feel more affiliated with mankind in general and want to help patients in general rather than just someone they know or they love. And the domino effect is amazing because, of course, any unspecified donor can donate to someone on the waiting list that doesn't have a living donor. But if you're smart and you line up particular pairs of incompatible live donor pairs that would otherwise not be able to be transplanted, you can line them up and make all these transplants happening, not just for those pairs, but also the patient on the waiting list is still benefiting from such amazing opportunity of having a living donor. The impact of cold ischemia time is quite well established that it's not a problem in UK living donor sharing scheme. There's also some American data that, of course, up to 8 or 10 hours, there have not been any issues with cold ischemia time. I'll skip through this a bit more quickly. In general, on average, in published literature, on average, the cold ischemia time is 4 hours for living donor transplantation. It could be much shorter, obviously, but it depends how you've organized your program. If there is more than 4 hours of cold ischemia time, there is a higher chance for delayed graft function and a poorer graft survival. So that was from the meta-analysis, and we were wondering if this would be true also in the UK live donor kidney sharing scheme that we published a couple of years ago. But basically, this is the key message here. There's no difference between a short and a long cold ischemia time. Even if you spread it out and analyze it per hour, up to 10, 12 hours that we have seen, reliable answers is that there is no difference in survival probability of the graft. And the risk factors for graft loss are actually exactly the same in the exchange programs versus the direct transplants. So those are the normal ones, like young age is always beneficial, preemptive transplantation. Of course, it becomes more tricky if you have your third or more transplant, and with a long warm ischemia time, there's more risk of graft loss and delayed graft function. When it happens, the risk of losing your graft is also higher. So no shocking things there, other than the main message that the outcomes of the kidney paired exchange program in the UK are very good, and at least the same compared to the non-kidney paired exchange transplants. So that is that. I already alluded to the strong multidisciplinary team requirements in collaboration with the referring units. I think, we all know what a multidisciplinary team could look like for living donation. You have surgeons, nephrologists, coordinators, anesthetists that are dedicated to the program, radiologists that know how to really look at CT scans for living donors, HLA scientists, but also psychologists or psychiatrists, and of course some specialized ad hoc staff, for example, learning disability teams, dietitians, and whatnot. The collaboration with referring units is important. We have a living donor coordinator attached to each unit to make sure that communication about recipient workup is streamlined with the donor workup to not lose too much time. And to make an easy referral via a central email address is also very useful. Transplant surgeons doing satellite clinics to expedite recipient workup is our model. And discussions, of course, with the referring nephrologist and advanced kidney care nurses in the MDT. So alignment of workup for recipient and donor is really important. And of course, we make sure that living donor coordinator also participate in any deceased donor waiting list meetings that we have as well. So it's all integrated. So the workup needs to be robust, but at the same time, we need to keep things easy for the potential donors, because that is, we know, very important. People need to, not have too many thresholds, not too many barriers to donate. So a health questionnaire could be incorporated digitally in the live donor referral pack. They can have virtual meetings with the live donor coordinator to have initial conversations, and then just get a blood group and HLA test done. We have one-stop shop investigations. We make sure that there is an early referral to a psychologist or psychiatrist if needed, especially for the altruistic donors, that we can review the results virtually, of course, and that we have regular MDTs with easy access for everyone. And of course, that in the UK, at least, every living donor pair gets to have approval by the independent assessor from the governing body of transplantation, the Human Tissue Authority, to make sure there's no coercion and no payment for the donors, and that the donors are really doing this out of free will. Here's the link to the BTS guidelines. Of course, there's KDIGO guidelines as well that are very good and often contain more or less the same information to see which donors are suitable. But also we've seen that the living donors from 20 years ago are different from those that we are seeing now. We see a lot of people with obesity. We see people who are elderly donors. My oldest live donor was 92, and we have a couple of 91 and 89. They're, of course, a minority, and not everyone on that age is suitable at all. But there are a few super grannies, so to speak, that actually can be suitable donors. People with medical issues such as high blood pressure, people with vascular multiplicity, and nowadays also younger people that are in their early 20s, for example, that want to donate have a different risk profile than elderly people. So it poses a lot more challenges than a long time ago. The informed consent procedure, those of you who are in the field or in different fields, you may recognize, of course, that potential donors may not want to hear the risks and may not want to listen to you. But of course, we always have to explain them what it entails. And it's really important that that this informed consent procedure is standardized so that we can tune in on any individual risks that are more applicable to this particular potential donor versus another one. So if you have a standardized procedure, it allows for more individualized discussions as well. And the questions for informed consent are, of course, what is an acceptable risk? How do we minimize or mitigate the risks? How do we determine the individual risk, as I was alluding to? And how do we communicate or explain the risks to the potential donor? Because not everyone has the same level of understanding. And how informed really is informed consent? And how do we assess that people really understand the information that we have given to them? Safety nets do we have in place? So this is an interesting Dutch survey for all the living donor surgeons of the Netherlands. We did that several years ago when I was still there. The risk of death, very simple. We said, okay, it's 1 in 3,000. And is this always discussed with particular donors? And only 52% of the surgeons disclose this always to every living donor. So I was quite shocked with this data. At least 40% sometimes discusses it, and it's never disclosed by surgeons, but 10% of the surgeons to potential donors, which is really shocking to see for me in a very high volume live donor country. And the reported mortality then, if it's disclosed, was between 0.003% to less than 1%. So a real big scope and a wide range of percentages that are being used. So we thought it was probably good to do a national study. What do donors actually know before they go into their workup versus right before they donate? And we did that in the PRINCE study that was recently published. So we looked at 2 cohorts, basically. We wanted to do cohort 2 as well when the informed consent discussions were recorded in the live donor clinic by the surgeon. But in the end, not many centers wanted to participate in this. They were quite scared with being recorded and if this had any legal consequences. So we just left it to cohort A and B. Just to show you the general picture is that cohort A is the people who are starting the workup. So they are completely sort of naive. And then cohort B is those donors that are actually about to donate the next day. And you will see that at least the general knowledge has increased about the recovery time, the surgical techniques they know much better than before, what type of complications they can expect in short term. But the long-term complications, people seem to have forgotten completely. And also, you see here lots of different complications that are mentioned, just to highlight the fact that death, again, is something that people try to ignore, or damage to other organs or other more rare complications. And long-term complications really stand out in terms of lack of knowledge for people, even at the moment of having surgery. So this is a surgical checklist we are using here at Imperial. Nowadays, it's even more extensive than this, with a few added risks about COVID and other fine-tuning. So we really use this as not as a tick box exercise, but to make sure that everyone has received that information at least, and that we check that they understand and know what this risk is about. And I always write in handwriting the specific risk that I think we have to disclose to that particular person. For example, if a patient is obese, the risk of an incisional hernia may be bigger. If there's multiple vessels, the operation time may be longer, or the risk of bleeding may be increased. So those kind of things are really allowing for more individual consent. And this is, of course, the future. We're already using lots of apps where we can calculate particular risks, such as end-stage kidney disease after a living donation. It's widely published by Dori Segev and his group and other groups. But we need to make sure it's valid for your population that you're working in. So, for example, Dori's population is very different from mine here in central London. So then a few words about operation techniques. And I think we started slightly later, so I have a little bit more time, hopefully. because the operation techniques have really been revolutionized in the early 90s by Lloyd Ratner first, and then Jonas Wattström also came in with his hand-assisted laparoscopic technique. And nowadays, of course, we have robotic-assisted operations and many variations on the particular laparoscopic techniques. The good thing is that, so what do you think here? The next survey question is the most used operation technique. While my presentation keeps going on, is this the hand-assisted laparoscopic donor nephrectomy? Is this the open or mini-open donor nephrectomy, or the transperitoneal laparoscopic donor nephrectomy, or the robot-assisted laparoscopic donor nephrectomy these days? Interesting to see your views. So let's vote. Always takes time to think about this very difficult question. So this is data we collected from a systematic review from all the published living donor transplants since the early 90s to now. And the right answer is indeed the transperitoneal laparoscopic donor nephrectomy technique, shortly followed by the hand-assisted laparoscopic donor nephrectomy technique. And interestingly enough, the open or mini-open donor nephrectomy technique, at least in the published data, and again, there's publication bias, is only accounting for 4.5%. But I know a lot of countries in various places in Europe, but also outside Europe, where, of course, they may not have the money for the equipment that the laparoscopic surgery requires. So probably there's much more open happening than we actually know or see published in the literature. But an increase in hand-assisted techniques, both laparoscopic and retroperitoneoscopic, and also a slowly increasing rate of robotic-assisted donor nephrectomies. So I can summarize the perioperative events and complications by this sort of meta-analysis and systematic review, that basically here you see the published complication rates per item. And we talked about it already, and there's quite a lot of detail in there, but very low complication rates in general. And of course, here in the literature, the death rate is 0.01%, so 1 in 8,000, compared to the reported 1 in 3,000 that we always quote, and surgical re-interventions in 0.6%. So the good thing is that the operation technique in the meta-analysis did not show significant differences overall in terms of complications. And that's, I think, really reassuring. So I've been teaching this course. I set it up in 2009 with my colleagues in Rotterdam, and it's still going. It's now an official ESOT course, the live donor nephrectomy course, where really we can operate on human corpses. And Jacopo has kindly been involved in quite a few editions as well, and many people in Europe as faculty. And we train people from all over the world throughout the years. And you can see it's not just Europe, it's many, many places from really far away, because this is the only course in the world that actually has this opportunity for people to practice a live donor nephrectomy, different techniques based on their demand on human corpses. And we have live demos, we have live cases in theaters with all the different techniques employed. We now have robotic assisted donor nephrectomy and kidney transplantation in the course as well. And it's only, short lectures about the theory. And there's basically a one-on-one expert faculty per participant. It also builds a network for people to find mentors in the field. And there's opportunities for proctoring if you want to start a program like this. And this is what it looks like, a lot of activity, but of course limited space because of the very expensive corpses and theater space. This is another thing we do in terms of training here at the Hammersmith, that we do the training for one particular fellow by one particular surgeon, and that there's a tailor-made approach to the trainee based on previous experience, of course, in general in laparoscopy or in the field of living donation, and we teach different techniques. So I'm a very big proponent of using the right operation technique for the right particular donor. So my standard technique is the purely transperitoneal laparoscopic technique, but also if the donor is obese, for example, or had previous abdominal surgery, I tend to use the hand-assisted retroperitoneoscopic technique, because then you can alleviate either the intra-abdominal fat, especially in men, or the adhesions that the previous abdominal surgery may have resulted in. And I use the hand-assisted laparoscopic technique if I can't develop the plane for a hand-assisted retroperitoneoscopic technique, or if during a transperitoneal laparoscopic donor nephrectomy there are difficulties or is not progressing very well, I just stick my hand in there and finish it hand-assistedly. And we do simulation training, for example, for conversion, because that normally doesn't happen. I've done it once in my career, and then there's an enormous amount of stress. So we regularly train theatre staff that what to do in case the horrible scenario happens. Long-term follow-up, I mentioned already. Education, I mentioned already how important it is, and using all sorts of media. And the UK is pretty good at that, with websites with lots of different movies by different people from different populations, so people can identify themselves with them in different languages sometimes even. And sometimes the BBC or so makes a whole program about living donation, like we had a few years ago here, which really helps the awareness of living donation. We have to go to extremes because we haven't really reached the potential of living donation yet fully, in my opinion. And I'll give a few examples by people that need a nephrectomy for another reason, for example, urological reasons or vascular aneurysms, that may still be usable. Also, convicted prisoners may still be able to donate a kidney if they are willing to do that. It's a very difficult population, of course. And sometimes people donate multiple organs, and those are really extremes. So we looked in Rotterdam at urological patients that donated with very good outcomes for the recipients and the donors. So people who otherwise had a nephrectomy and the kidney would have been thrown out, or an autotransplant would be done, where patients don't always want an autotransplant or need an autotransplant and are presented with the opportunity to donate. And many people actually want to do that. Seriously ill patients who have a life-limiting disease, such as a neurodegenerative disease, may want to do that as their last good act in life. We've had a small series in Rotterdam that we published on that, and donate as altruistic donors while they're still alive and can, be comforted with the fact that at least they helped someone else or multiple people. Lots of ethical aspects there. Public solicitation is really interesting, and it's happening in many countries at the moment in social media. So just a little exercise, what happens. So you can imagine if she would appeal for a living donor on social media, she probably would get quite a few offers of potential donors or not. What about him? Is he the patient and he puts out an advert that he needs a kidney transplant? What do you think would happen? Would there be more people or less people that come forward as potential donors? And of course, this culprit, if he would step forward, would he even get one potential living donor? We don't know. So life donation philosophy, it's about education, it's about passion, it's about early referral, it's about evidence-based information that we provide to our patients, and move away from the defaults that we have all established on. And even there's many people who even call it the dialysis mafia, mafia is that dialysis is even in some countries in Europe mandatory before people are even eligible to get a transplant. That's, of course, completely ridiculous and would go against any ethical best medical practice. We have to push for preemptive transplantation because there is evidence that this is better. And if you compare this again to cancer surgery, if you know surgery A versus surgery B is better, then obviously everyone would move to surgery A if it's possible for their patients. But it doesn't seem to happen with preemptive transplantation much. And we have to extend our criteria for living donation to make them make donation possible. So all the other things we've already mentioned. I'm very passionate, and I hope that I've transferred a little bit of passion to you to see if living donation in Europe can be increased and improved. I'll stop here. Thank you so much. And I'll stop sharing my screen. think you're on mute, Jacopo.
Okay, so thank you very much, Frank, for this very detailed and accurate and especially passionate review of living donation in kidney transplantation. So I think we still have some time to answer a few questions.
There's a few that I can see that are in Turkish.
Yes, but there is a translation here. What is the percentage of laparoscopic procedures in your patient series? And what is the average cold ischemic time?
What is the percentage of laparoscopic
Procedures in your patient series?
In my patients here, we are nearly 100% laparoscopic. There's one surgeon that still does many open donor nephrectomy, but most patients are keen to have a laparoscopy these days. And then the
second average cold ischemic time?
Average cold ischemia time between 2 and 3 hours, because we are doing it donor first, and when we have the kidney out, the recipient comes into the anesthetic room, and then we bring the recipient in as soon as the donor operation is finished. So that is relatively short. But of course, if you would have multiple theaters at the same time available, which we don't have, just to theater pressures, then you could, of course, minimize that even further. But there's no evidence that 1 hour versus 2 hour is better. It's nicer, but I'm not sure if it's better.
Okay. And then we have another question. How do you make sure couples adhere to the proposed donation and transplantation in a transplant chain?
Yeah. So actually, there is not, because all these operations happen most of the time on the same day at the same moment. So, for example, if we have a four-way exchange between, so 4 centers, we make sure that on the day, the living donor coordinators are in touch with each other. We all start at 8 o'clock, and we only go knife to skin. We only anesthetize the donor when all the donors and the recipient have been given the green light and they're fit. Of course, things can happen during the surgery that the donor has unexpected findings or becomes unstable or has an arrhythmia or something like that. Then, of course, then there is a problem. But this hardly ever happens. And in the UK, we do also non-simultaneous exchanges. And then we normally let the altruistic donor donate as last, because they have the most sort of endogenous motivation to donate. And they're not thinking, oh, my mother had the kidney transplant and now I'm going to bail out. Of course, these things have happened, but it's a disaster if that happens. But there's always a solution for that. And the people who miss out on a transplant in any chain in the UK get priority for a deceased donor transplant, or an altruistic donor live donor kidney transplant.
Okay, we have a fourth question. Have you ever heard of a donor in a chain pulling out in a non-simultaneous donor?
Yeah, that happens, I think, once every so often years. Of course, we like to know really beforehand. We recently had this in another center in London, where we were going to have a kidney, we were going to receive a kidney for a wait list patient, or end of a chain transplant. And that particular donor left that hospital early in the morning and bailed out and was never found again. So probably completely disappeared from the radar. And of course, this was a deceased donor wait list patient. So this particular patient, for them, it was anyway a bonus. Thankfully, the patient, could only understand, and there was nothing else we could do. But of course, these incidents are always investigated very thoroughly by all the governing bodies to see if there's anything that we could have picked up earlier, that particular center, than for that particular donor. Because if people express any doubt directly or indirectly, it's much better to wait and make sure that no one else gets jeopardized, especially if it would have been another recipient of another pair. and not just a waiting list patient, even though I find it horrific for that particular patient too. But yeah, so it happens sometimes.
And there is an additional question from the same participant. I'm thinking how to arrange this in a third world country.
I presume that Tahawa means the exchange programs. Yeah, I mean, I speak a lot with people in third world countries, and they often say, of course, this is nice that you're presenting us with that, but in our country, we can barely transplant. And totally understand, obviously, and I think we need to get the basis right first. So I think the most important thing is to have a living donor transplant program and then take it step by step. But there's lots of people actually that are doing work with third world countries and try to help people setting up programs, even exchange programs. And I think if this is done nationally with government support, that would also be very cost efficient for the countries, especially third world countries, where dialysis is very costly and difficult to organize as well. So I would argue that it's still really worthwhile trying to collaborate within, ESOT, within the UEMS. We're all here and all happy to help thinking about it and setting it up even.
Excellent. Oh, okay. There is another question. Oh, thank you. Tahwad is thanking you. Okay, so if there are no additional questions, I would like to thank Frank for his participation today to this very interesting webinar. Thank you very much, Frank. Thanks to Sebastian as well. And before we leave, I would like to show you what's next. The next webinar will be on the 14th of September. The topic is still to be defined, but it will be organized by the Multidisciplinary Joint Committee on Upper GI Surgery and the Emergency Surgery Division in cooperation with the Thoracic Surgery Section of the UEMS. Then there are some additional infos regarding the next sessions of the exam. DBSQ in coloproctology in June, 29 and 30 September, deadline for application on the 7th of June. Then in September the 16th, during the ESOT Congress, the European Society of Organ Transplantation, there will be our exam, the Division of Transplant Surgery exam in Athens. And there's still room for application. The deadline is on the 29th. And there are then two additional dates, important ones, 13 and 15 September for DBSQ in general surgery, and the 30th of September for DBSQ in hepatobiliary and pancreas examination in GAN. So thank you very much for participating to this webinar. You can still follow us on Twitter and LinkedIn, and learn more about us on our website. Thank you very much.
Thank you. Bye.
Bye-bye.